Hi everyone. Today's presentation will look at the drug library for the CADD Solis VIP Ambulatory Infusion Pump Model 2120. All information provided in this presentation is specific to Ontario Medical Supply, as this is the pump currently being used. In our experience, most of the mistakes that occur when using this pump are due to errors associated with drug concentration and changing the protocol. The purpose of this presentation is to increase infusion therapy safety when using the CADD Solis pump by increasing knowledge and understanding of the pump library and protocol design, dose calculations, navigation of menus when making changes to any settings or protocols, pump limitations that are set by the manufacturer, and library limitations that are set by the pharmacy. We will start with defining and understanding the drug protocols that are available in the CADD Solis pump. A drug library is a comprehensive list of medications or fluids that are to be delivered using the infusion pump. The library includes the drug, dose, volume, and rate limitations, which are pre-programmed into the pumped software. In a CADD Solis pump, the library is referred to as a protocol library and consists of a collection of protocols. These protocols vary depending on the drug being infused. Data is collected about each specific medication, and limits are set to ensure safe administration processes are in place. For example, the drug vancomycin can have adverse effects if administered too quickly. Therefore, the vancomycin protocols are set so a clinician cannot program the rate outside of the recommended parameters. The protocol is a unique combination of all of these components. We will go over each component in detail in the next few slides. In the CADD Solis VIP pump, the therapies are predefined. There are 5 therapies available, but only 3 are used by OMS in the current library. PCA, as named, is for patient-controlled analgesia. Most of our pain management medications are included in this therapy. Continuous is used anytime we want an infusion at a constant rate over a certain period of time. It could be over half hour, as we would see with single-dose bags of antibiotics, or it could be over 24 hours, as could be the case with fluids for the purpose of hydrating a patient. For example, if we are to administer a single dose of IV Vanco once a day over an hour via pump, we could choose the vancomycin protocol in the continuous therapy to infuse over an hour. Intermittent is mainly used for antibiotic therapy. It allows the infusion of a specific volume at regular intervals throughout the day and over a specified duration. Still using vancomycin as the example, if it were ordered more than once a day, for instance every 12 hours, we would choose the vancomycin protocol in the intermittent therapy. In a hospital setting, the qualifiers are typically set according to area of usage, an example being the ICU or oncology department, or by population, such as TPN patients or pediatric patients. This narrows the search criteria when looking for a drug. Because there are various conditions and treatments offered in a single setting, the community, it is difficult to set the qualifiers based on area or population. For this reason, in our library, the qualifiers are in fact the name of the drug. Continuous and intermittent therapies are set with the qualifiers being only the name of the drug because the parameters for infusion are the same regardless of whether the infusion is through a peripheral line or a central line. PCA is more complex because we administer medications via the subcutaneous route or the intravenous route. These 2 routes differ greatly in the amount of volume to be administered over a specific time. For example, you can administer a higher volume of fluid intravenously than you would subcutaneously. So for the PCA qualifier, the route of administration will always be included with the name of the drug. For example, morphine IV and morphine sub-Q. There are a few exceptions to this, which we will highlight further on in the presentation. Let's take a moment to recap what we have discussed so far. A protocol is the unique combination of all elements. Therapy is the predefined delivery mode, of which we use 3 in the community. These are PCA, continuous, and intermittent. A qualifier is set to the drug name, and when choosing the PCA therapy, the drug name and route. All right, let's continue. Now we will take a closer look at the drug. The drug can be comprised of the name, dosing unit, and concentration. This is dependent on the therapy selected. For instance, in PCA therapy, the dosing unit will determine if the drug has a concentration. We will look at each component in more detail. The drugs are all programmed using the generic name, except for Septra, which is very rarely prescribed in the community. Tallman lettering, otherwise known as caps lock, is used to differentiate between drugs that have similar names. The dosing unit is important because there are differences between drugs in the units they are measured in. For example, fentanyl is dosed in micrograms, and morphine and hydromorphone are dosed in milligrams. There is a significant difference between these values, and it is imperative that clinicians are aware of the proper unit of measure for each drug. So let's break it down and start by looking closer at milliliters. All drugs with no associated concentration will display in milliliters, and this is a standard unit of measure for all drugs and fluids in the continuous and intermittent therapies, as well as the exceptions in the PCA therapy, which we will still discuss in more detail later in this presentation. Moving on to milligrams and micrograms. When these units of measure are used, a concentration must be associated with the drug. This is typically set in the library for you. However, if there is ever an instance where you need to program manually, you will need to select the appropriate unit of measure. Based on this, the pump will prompt you to select an appropriate concentration. Drug concentration is mainly used in PCA therapy. In the pump library, a drug concentration is always going to be the amount of drug available in 1 milliliter of solution. It is always expressed as a ratio. There is only ever one concentration to be programmed into the pump. So how would you select a concentration if you had an order for 2 drugs on the same pump? You wouldn't. And we will go into more detail about what to do when you receive an order for more than one drug with a concentration shortly. The pump can deliver a very wide number of concentrations in milligrams and in micrograms. Concentrations used to build the library are based on a 6-month history of all LIN prescriptions. These concentrations can cover a very wide range of rates and doses. Limiting the number of concentrations available for each drug can minimize the risk of pump programming errors. Whenever possible, prescribers are encouraged to use the concentrations that are available in the library and refrain from manual programming. The home infusion department will notify the prescriber if the concentration is not currently in the library. Having said that, if you are in the home and the orders are not in the library, you can program manually by scrolling to the very bottom of the qualifiers list. Pharmacy should always be notified when this occurs so they can determine if this new concentration needs to be added to the library. Remember, all concentrations will be listed based on a milligram or microgram per 1 milliliter. The amount to be infused will always be the prescribed rate divided by the concentration, and same for the bolus dose. So far, we have learned the concentration is part of the drug's name and the drug is part of the protocol. Therefore, choosing the right protocol is critical. Pump errors causing the most harm are the ones related to concentration. Concentration-related errors could result in overdosing, which can be fatal, as well as underdosing, which can quickly prompt a pain crisis. Smart pumps, such as the CADD Solis VIP, are loaded with a dose error reduction software, which employs safeguards for each drug selected in the library. These safeguards are only as good as the person programming the pump. All safeguards fail if we choose the wrong drug or concentration and protocol. Here is an example of how the wrong concentration can affect the patient. The prescription reads hydromorphone 10 mg per ml with a rate of 1 mg per hour and a bolus dose of 0.5 mg. To figure out the rate, we need to divide the 1 mg by the concentration, which is 10 mg. This gives us a volume of 0.1 milliliter. To figure out the bolus dose, we need to divide the prescribed 0.5 mg by the concentration, 10 mg. This gives us a volume of 0.05 milliliters. In this instance, an incorrect selection of the drug was made. Hydromorphone 1 mg per ml was selected instead of 10 mg per ml. Although the pump calculations are correct, the safeguards failed because the wrong drug and thereby concentration were selected. I mentioned previously there are some exceptions for the PCA therapy mode. Let's discuss these now. One exception to dosing in milligrams or micrograms is when you have an order for 2 or more drugs in one medication reservoir. These are known as combination drugs and will be dosed in milliliters. Although the medication label will provide you with the name of the drug and the concentration, the pump will only display the name of the drugs in the combination. When prescribed, prescribers will determine the dose of each medication and based on that, determine the appropriate concentration for each medication. Here is an example of what the combination drug label looks like against the pump screen. You can see in the pharmacy label the information will be available. However, the pump will not provide you with the option of selecting concentrations. This is because there are so many variations of concentrations based on dosing, and the prescriber is responsible for the calculations. Another exception in PCA therapy is for epidural and intrathecal drugs. Again, this is because they are often a combination of 2 or more drugs. The dosing unit in milliliters is determined by the prescriber. The label and pump function will appear the same as the example you saw previously. It is important to note that combination and epidural intrathecal drugs are labeled as such when selecting the qualifier. The last exception is for one-off drugs that are not historically administered via pump, and the prescriber has asked for a label within the library so the pump would display the medication name. Drug labels also exist in the intermittent therapy for drug doses based on weight or trough levels, such as aminoglycosides, that can be prescribed anywhere from every 24 hours to every 6 hours, and in the continuous therapy for single doses based on weight, such as acyclovir. Ranges are based on total volume to be infused. Here is an example of how the drug names are displayed in the library. Delivery settings are the programmable parameters in each therapy. For PCA, it would be the continuous rate, the PCA dose, and the PCA dose lockout time. They are each associated with a starting value and soft and hard limits. For example, for the subcutaneous route, the soft limit for the hourly rate is 2 milliliters, and the hard limit is 3 milliliters. The pump will allow you to program past the soft limit, but not the hard limit. If you go past the soft limit, the bar you see in the picture in green will turn orange to alert you are getting closer to the hard limit. For the intravenous route, the limits are higher and can go up to 6 milliliters. This is why it is very important to choose the appropriate qualifier, which again is the name of the drug and the route. If not, safeguards included in the soft and hard limits for each route of administration would fail. The increment is the value by which we can increase or decrease a dose. The increment is preset and cannot be modified. An example of this would be fentanyl 40 micrograms per milliliter. The bolus dose is only adjustable by increasing or decreasing by 2 micrograms. So you could give 24 micrograms or 26 micrograms, but it will not allow you to give 25 micrograms. Now let's look at the actual structure of the library. Okay, so now that we've explained each section in detail, let's discuss how the protocols are built. The administrator has to select a therapy, select a qualifier, select a drug, and set the initial values and soft and hard limits for each programmable parameter. This is an example of the PCA therapy. The qualifiers, as we've learned, are represented by the drug and the route of administration. Once you have selected your qualifiers, you can see the list of available drugs represented by the name of the drug and the concentration. Here is an example of the intermittent therapy. The qualifiers, as discussed before, are represented by the drug name itself. There is no route here because, unlike PCA, the route is not a limitation. These drugs are all intended for intravenous infusion. Once the qualifier has been selected, you will find under the drug which contains all therapeutic doses and frequencies without exceeding the maximum daily dose allowed. A generated report called All Active Protocols is a great tool to identify what is in the library and what is not. This document can be shared with the nursing agencies as an electronic PDF. So now let's look at how to select the protocol when you need to program the pump. If you focus on the first image to the left, you will notice the dark purple portion at the top of the screen has no information. Once you select your therapy, in this example we will select PCA, and move to the middle image, you will notice the therapy is now displayed in that top portion of the screen. Next, you select your qualifier. Here in this example, we will pick morphine sub-Q. Moving over to the image on the right, you will now notice our selection has been added to the top portion of the screen. Now that you've selected the appropriate qualifier, you will need to choose the concentration that matches the prescriber's orders and the pharmacy label. All three need to match. Once the three components of the protocol are selected, a screen with a summary of your selection will appear, and the pump will prompt you to confirm that the information is correct before proceeding to reviewing and accepting the delivery parameters. The most important step in checking the programmed protocol is to check and confirm this screen. Remember, the pump is loaded with a dose error reduction software, but all safeguards fail when the wrong drug or concentration is chosen. Once the protocol selection is confirmed, the pump will prompt the user to review pump settings and accept value. The protocol details, including drug name and concentration, are always displayed on the top part of the screen when reviewing pump settings and accepting values. From the main screen, regardless of whether the pump is running or not, pressing the Tasks key will bring back the top box with the protocol selection to the screen. Remember, you need to check the entire screen and not just the portion in light purple. The concentration listed above needs to be included in that check. Now that we have discussed the programming of the pump, let's spend a minute talking about the validation process. It is imperative when programming any electronic infusion device, the clinician verify the programming to both the original order and the prescription label. Let's not forget, error can occur at any point, and as the clinician administering this medication, you are accountable for this verification process. Remember, all safeguards fail if you choose the wrong drug concentration. Verification includes checking the orders against the prescription label and the orders and prescription label against the programming on the pump. This is done including the entire contents of the pump screen and not just the portion where you accept values. Next, we will go over how to make changes to the pump programming for patients already receiving therapy via the CADD Solis pump. When there is a change of concentration, the pharmacy will affix a label on the container advising the clinician to change the concentration and reprogram the pump. Do not let this change the validation process. The pharmacy has put multiple safety checks in place to ensure that changes are highlighted, but you, the clinician, are the last licensed healthcare provider between that drug and the patient and are accountable for performing your rights of medication administration. To change the drug or concentration for a patient already receiving medication, go to the Tasks menu and from there select View Advanced Tasks. In the Advanced Tasks menu, select Start New Protocol, Same Patient. As mentioned, Start New Protocol, Same Patient applies to existing patients with a change of medication or concentration. Selecting this option will ensure the pump will keep the history from the last protocol used. This is important for many reasons, especially in pain management, so we can track trends and ensure the patient's pain is being controlled appropriately. The highlighted areas in pink in the picture provided are where you will notice changes in concentration. So what we've just discussed was how to change the drug or concentration when orders change for the same client. Now we will get into how to change the delivery settings. An example of this would be when you are titrating doses for pain management. In this case, we do not want to change the drug or concentration. We simply want to change the amount of drug or volume the patient is to receive. For this, you do not need to go into the View Advanced Tasks menu. From the main Tasks menu, you would choose View Delivery Settings. The portion highlighted in yellow on the prescription label are all of the components that make up the delivery settings. The prescription instructions are written using the pump language and are in the same sequence they appear on the pump screen. This slide is included as a reference in case you need it. It simply shows what I mentioned in the previous slides. Here you have a list of what appears in the delivery settings based on each therapy. Again, this slide is included for your reference. It summarizes how and when to perform each action. Most errors occur when selecting or changing a protocol. Do not change the protocol to change the delivery settings. Any changes that need to be made in any area of the prescription instructions should be done using View Delivery Settings. Here is another great reference slide for you. The table represents the concentrations that are available in the library, mainly for morphine, hydromorphone, and fentanyl. It shows the starting value, which is the smallest dose possible, and the increment by which you can increase or decrease the dose. It shows the limitations set by the manufacturer for the continuous rate and bolus dose. Going back to the example of fentanyl 40 microgram per mil, you can see on the right side of the screen the bolus dose can only be moved in increments of 2 micrograms. Keep in mind, concentrations that are not represented in the table and would require manual programming also will have set limitations. The library also has some limitations related to the route of administration and therapeutic doses. This is represented by the soft and hard limits. For example, the hard limit for the subcutaneous route is 3 milliliters and the hard limit for the intravenous route is 6 milliliters. We will end the presentation with some case study examples. So the first patient, Mr. A, was prescribed morphine for pain to be given subcutaneously. The concentration indicated on the prescription was for 50 mg per ml with an hourly infusion of 5 mg per hour. The pump was programmed for this and the infusion was started. The order was then changed to titrate the hourly infusion down to 4 mg per hour. However, the clinician was unable to do this and was not aware of the pump's minimum rate of 5 mg with a concentration of 50 mg per mil. Unknowingly, a new protocol was selected and a concentration of 4 mg per mil was chosen. The new hourly dose of 4 mg was programmed. With the new concentration and rate programmed, the pump delivered 1 ml an hour. Because the actual concentration of the medication was 50 mg per ml, Mr. A received 50 mg an hour, which was 12 times the intended dose. In this case, this patient was a new admission. The prescriber chose a very high concentration to start with, that being the 50 mg per ml. Due to pump limitations, the lowest possible dose was 5 mg per hour. This doesn't leave any room to titrate to a lower dose if needed. In this instance, this is what happened. They needed to titrate the dose down to 4 mg and were unable to do so with a concentration of 50 mg per ml. The protocol was changed to a different concentration, which allowed the clinician to program a continuous rate of 4 mg per hour. If the clinician was aware of the pump and library limitations, they would have been more likely to contact the prescriber or the pharmacy instead of changing parameters and putting the patient at risk. In the case of Mr. A, it should have been recommended this patient start with a lower concentration. Understanding the pump library and delivery functions can flag the clinician when faced with such a high starting concentration. In the second case, Mrs. B was receiving hydromorphone at a concentration of 4 mg per ml. The order was changed to increase the concentration to 10 mg per ml and the rate to 1.8 mg per hour. The clinician, who was having difficulty changing the concentration, ended up changing the rate to 1.8 mg per hour, but kept the concentration at 4 mg per ml. The pump delivered 0.45 milliliter per hour of the 10 mg per ml concentration, which makes the actual dose received 4.5 mg per hour instead of 1.8 mg per hour. This is the huge risk with concentration. For the rate to be correct, the concentration has to be correct. In this case, because the clinician did not change the programmed concentration but changed the cassette with a higher concentration, the patient received a rate 2.5 times than was prescribed. Here we have the correct steps needed to change the concentration. From the home screen, press Tasks to enter the task menu. From there, select View Advanced Tasks. Here is where you will find the option to change the protocol for the same patient. When there is a change in concentration, the pharmacy will affix a label indicating there is a concentration change and the pump needs to be reprogrammed. Here is the information for the operator's manual for the CADD Solis VIP ambulatory infusion pump model 2120. Thank you very much for taking the time to listen to this presentation, and we hope it'll help you in your future practice.